The goal of this presentation is to educate our audience on the use of cannabis in Missouri for both medicinal and recreational purposes, and to kind of get a feel for where our state is at today with the regulation of this cannabis, as well as the history and medical benefits of cannabis. The Missouri Cannabis Trade Association is an association of several entities, including business owners, healthcare providers, professionals, and patients, whose goal is to implement a successful, safe, and compliant marijuana program in Missouri. This trade association represents its members in the industry by working with entities such as the Department of Health and Senior Services to develop and implement sensible, proven policies, rules, and regulations. The Health and Education Board of the Missouri Cannabis Trade Association has members with decades of medical experience, whose goal is to serve as educational resources for their peers, medical schools, and healthcare systems to educate them on the proper use of medical marijuana as a medical treatment option. So how did we get here in Missouri? In 2018, Amendment 2 was passed by Missouri voters, which then became Article 14, allowing the right to access medical marijuana. Recreational use was passed in Missouri in 2022, with the first recreational sale occurring in February of 2023. Despite this, marijuana remains classified as a Schedule I controlled substance by the DEA. It is the physician's responsibility to know and comply with the laws in the jurisdiction where they practice. Therefore, this primer is intended to provide basic information about cannabis to healthcare providers. If there are questions, the provider is instructed to contact the Missouri Department of Health and Senior Services, Division of Cannabis Regulation, or to seek legal counsel for further information and guidance regarding all state and local regulations. This next slide shows that in 2022, Missouri voters passed Amendment 3 by a 53% margin to 46% margin, legalizing the possession, sale, taxation, and regulation of marijuana for adults 21 and over. This includes a 6% retail tax, and of this, funds are earmarked for both veteran care initiatives, a public defender program, substance abuse and misuse treatment programs. An additional 3% local municipal sales tax can be applied by voter approval. In addition, Amendment 3 provided some updates to Article 14 and the medical marijuana program rules, including that a medical marijuana patient ID is valid for 3 years. It also provided patient protections with a valid patient ID, protecting against some discrimination, as well as some employment, tenant, and family court issues. It confirmed that the medical cannabis tax rate remained at 4% and continued to support the Missouri Veterans Commission and Veterans Care Initiatives. This article also states that no more than 2% of the total taxes for medical marijuana will go to the Department of Revenue, and it will allow the Department of Health and Senior Services to carry out its responsibilities. It also confirms the Missouri Veterans Commission under the Missouri Veterans Healthcare Fund. In addition, proceeds from adult use marijuana will go no more than 2% to the Department of Revenue. It also provides for the Department of Health and Senior Services to carry out its responsibilities. It supports Missouri Veterans Commission, and it provides for a Missouri public defender system and local governments if the local government taxes marijuana sales. So what are a provider's responsibilities in Missouri when discussing medical cannabis with your patients? Qualifying conditions for a patient are defined very clearly under Article 14 of the Missouri Constitution. As a physician, we are not advocating for the use of marijuana to supplant any standard of care, but rather to provide that as a complement to alleviate symptoms and improve quality of life. So the overall intent of this presentation is to give physicians options that they can then clearly and safely discuss with their patient, informing the patient to allow them to make the best decision for themselves, but also protecting the physician from any legal action. One question I get a lot from my patients is, am I writing them a prescription for medical cannabis? And this makes it clear that this is not a prescription, it's just an attestation that the patient has a qualifying medical condition. So that license that they have then is good for 3 years. It must be completed in its entirety and signed by the physician. It has to be done within 30 days prior to the patient submitting their online application. And then if the patient requires more than 6 ounces per month, they will need an additional attestation provided by an MD, DO, or NP. In Missouri, the physician must hold a Missouri State medical license as an MD or DO. Nurse practitioners are qualified to write, but assistant physicians, PAs, and chiropractic doctors cannot certify. The physician and nurse practitioner responsibilities, of course, include continuing to advocate for their patient's health and to complete the physician or nurse practitioner certification and to assist the patient registration. However, I do also provide education and guidance on available forms of medical cannabis, as I think that aspect is very important. Consider a senior citizen who's never consumed cannabis and you tell them to simply go to a dispensary, buy medical cannabis and consume it. I think you're better off guiding them through that process. However, the dispensary is supposed to educate the patient on available forms and usage as well. In addition, the physician and nurse practitioner should of course follow up with their patient to check in on how things are going. You can see here that the provider protection is quite clear under Article 14 of the Missouri Constitution. To become a certified provider, one must first go to the DHSS website and register for an account under their registration system and submit a physician registration application in order to be verified. Once this is complete, it will allow that account to submit electronic patient certification forms. Tutorials provide step-by-step guidance for physicians and nurse practitioners to register and become verified, and this website is quite easy to use. I do recommend watching the short video tutorial on the DHSS website. Once again, these websites are quite user-friendly. They don't take long at all to certify a patient once you've seen them, and I have very good feedback from patients of all ages and really any type of computer knowledge that the system is quite easy to use. So as a patient, the steps are quite clear. First, they come to their provider to get a medical certification. The provider submits a form to the DHSS website. The patient then goes to the same website and registers with DHSS, submitting an application form and fees via the online portal. And once they're approved, they receive a card allowing them to purchase 6 ounces a month at a dispensary. They then take that card to a dispensary where the wellness agent will educate the patient on available products by form, strain, and dose. And then the physician should see the patient and follow up, continue to see how things are going with the patient. Here you see various qualifying medical conditions, including cancer, epilepsy, and glaucoma, but really any chronic medical condition that causes severe and persistent pain or muscle spasm, and then any chronic medical condition that is normally treated with a prescription medication that can lead to physical or psychological dependence. So the categories are quite broad, and leave it up to the judgment of the provider. Now we're going into a brief history of medical cannabis. Medical cannabis has been around for really many thousands of years. The earliest data we have is from China around 2500 BC, where cannabis was consumed as medicinal tea. And then 100 years later in India, the Hindu religious festival had a drink called bhang, which included cannabis mixed with various spices and nuts. In the 800s, Queen Victoria quite commonly was known to be prescribed cannabis tincture for menstrual cramps by her personal physician. This cannabis was even listed in the U.S. Pharmacopoeia in 1850. Finally, Sir William Osler, the father of modern medicine, in his textbook listed cannabis as the most satisfactory remedy for migraines. Moving into the 1900s, a very famous person, Raphael Mechoulam, was known as the father of cannabis. He isolated the endocannabinoid anandamide and 2-AG in 1992. The first legal medical cannabis in the United States was Proposition 215, the Compassionate Use Act, which was passed in California in 1996, allowing medical patients access to cannabis. Now, after the year 2000, currently 41 states have medical cannabis, with Missouri again becoming medical in 2018 and adult use in 2022. So looking back, we see medical cannabis listed in the U.S. Pharmacopoeia in the 1850s. We see Sir William Osler speaking of the benefits of medical cannabis in 1892. Why are we having to legalize this today? Well, in 1937, the Marijuana Tax Act was passed. This effectively stopped hemp production and placed penalties on users and growers. This was opposed by the AMA as the tax impacted doctors and pharmacists. And this tax act, if you look behind it, was supported by large paper companies such as Hearst, Mellon, and DuPont, as natural hemp paper could cripple their wood paper or synthetic fiber business. The AMA discontinued its support of cannabis as medicine at that time. In 1970, the United States Congress rescheduled marijuana as a Schedule I drug. So why did that happen? Many people feel this was pushed by President Nixon, who wasn't doing well politically at that time, and he used this as a way to mobilize voters to destroy the anti-war left. The National Commission on Marijuana and Drug Abuse then engineered scientific support for Schedule I placement. It was then not acceptable for medical use and deemed high potential for abuse and placed in the same category as heroin, MDMA, and LSD. So that was in 1970, which is quite a long time ago. Why do we think our government continues to schedule cannabis as Schedule I? Well, there's some thoughts behind this. Since 2003, the NIH has held a patent on cannabinoids as antioxidants and neuroprotectants. And if you see in the highlighted section here, it's quite clear that cannabinoids have far-reaching medicinal properties, which are clearly described here. So if the government profits from the health benefits of certain cannabinoids, then cannabis does not fit the Schedule I definition of having, quote unquote, no current accepted medicinal value. Many people are questioning the rationale here. And by maintaining cannabis as Schedule I, the NIH ensures it doesn't have any competition. Let's now look at the U.S. legalization landscape as of January in 2023. At that time, 41 states had medical cannabis. 23 states, including Washington, D.C., had adult use or recreational use laws. If you look at the population, 89% of Americans support legalization of cannabis for medicinal treatment, and 69% of physicians support nationwide legalization of medical cannabis. In Missouri, in October of 2023, there were over 54 cultivation facilities with over 75 processing or manufacturing facilities, 10 testing labs, over 200 dispensaries, over 24 transportation businesses, and 48 micro businesses. So really, the advent of this program starting in 2018 until today has really had a rapid growth in the state of Missouri.
I'll be discussing how medicinal cannabis works in the human body today, how we believe it works, and there's quite a lot to unpack here, so get going. The endocannabinoid system is essentially a modulatory system that maintains homeostasis throughout almost all known biological processes in the human body. So I believe the main function is to maintain this homeostasis. And it's been revealed that the endocannabinoid system, or ECS, is incredibly old, having evolved with us over a period of possibly up to 500 million years. It's present in anything on the evolutionary chain moving forward with a backbone forward. So it's been with us quite some time. It's an ancient system. It was initially suggested that we only would find these endocannabinoid receptors and molecules being present in brain and nerve cells, but we've later found that these innervate almost all systems, if not all systems, in the entire human body. And this includes everything outside in, from our skin, cells moving inward to immune, bone, fat tissue, liver, pancreatic tissue, skeletal tissue, muscle tissue, and we found this is, again, involved in a wide variety of processes, including pain, memory, mood, appetite, stress, sleep, metabolism, immune function, and we also know that it has a role in reproductive function. The ECS, or endocannabinoid system, is a neuromodulatory system. That means that it's able to affect neurotransmission. These receptors, endocannabinoids and cannabinoid receptors, are very important in neurosignaling. We know this because when we look at different brain cells like neurons, which are important for signaling, or astrocytes, which are glial cells important for support, and microglial cells, which make sure that the CNS is free of pathogens, we see that there are cannabinoid receptors in all these components. The endocannabinoids work by acting as negative feedback, and they slow neurotransmission. They do this in a process called retrograde signaling that we'll discuss more in a moment. So the endocannabinoid system has four major components: endocannabinoids, which are produced in the brain; receptors, synthesizing enzymes, and on the other hand, the degrading enzymes, and these all work together. Endocannabinoids are the ligands that are produced by the body, so endo meaning inside, cannabinoids meaning cannabinoids. So these are produced in and by the body. These are going to interact with the endocannabinoid receptors. The first two discovered endocannabinoids and most studied were anandamide and 2-AG. However, we found that quite a few more exist. In terms of cannabinoid receptors, our classical cannabinoid receptors are CB1 and CB2, also known as CB1R and CB2R. These are G-coupled protein receptors. So recently, G-coupled protein receptor 55 has also become classified as a cannabinoid receptor. But even though this receptor has a different gene sequence than CB1 and CB2, it operates by a mechanism that's very similar. And that's why we have considered it to be part of the classical cannabinoid receptor family. Endocannabinoids can also interact with a variety of other receptors, and these include other G-coupled protein receptors like GCPR119. We also know that they can have effects on transient receptor potential vanilloid receptors, or TRPV1, which are cation channels, and we know that these can also have influences on PPAR gamma and PPAR alpha, or they can also influence peroxisome proliferator activated receptors, gamma and alpha, respectively. All these receptors then go on to affect how genes and different things are transcribed within and generated by cells. The endocannabinoid system has its own system for synthesizing the two main endocannabinoids, AEA, or anandamide, and 2-AG, as well as the degradation enzymes. So these synthesizing proteins come into play when the endocannabinoids are originally made, and the degrading enzymes are going to be what's responsible for stopping activity of the endocannabinoids at the receptor level. On to discussing the different types of cannabinoids that can interact with our endocannabinoid system. We have number one, the endocannabinoids. These are internally derived or brain derived, some label. These mean our body produces these, and they work to maintain our own endocannabinoid system homeostasis, or a homeostatic tone, endocannabinoid tone within the body. Second type are phytocannabinoids, or plant-derived cannabinoids. When we discuss cannabis, we're discussing the plant-derived cannabinoids such as THC and CBD that can affect how we respond to internal and external stimuli. And the third type of cannabinoids are the synthetic or lab-derived cannabinoids such as delta-9 THC, known as dronabinol or name brand Marinol. That would be a synthetic lab-derived cannabinoid. We also have other examples that come to mind, but I don't have the names of those molecules with me, so we'll move forward. Let's now talk a little bit about characteristics of two main endocannabinoids we produce. Those two main endocannabinoids produced by humans are 2-AG and AEA. These are produced on demand in response to increased intracellular calcium concentration. These have a short half-life, and they have an overall distribution in different brain areas that appear to be similar. They have, again, a short half-life, and even though they have this short half-life, they can have profound downstream effects effects meaning the biological response to these interacting with the cannabinoid receptor. Even though they have a short life, they can have profound effects down that biological pathway and cascade. 2-AG and anandamide, these are found in higher levels in the brainstem, the striatum, and the hippocampus, and we see lower levels in both the cortex diencephalon, and we also see lower levels in the cerebellum. It's been proposed that 2-AG is the primary signaling endogenous cannabinoid in the CNS, and we found that that makes sense. And now we will move on to cannabinoid receptors. There are two most discussed cannabinoid receptors in literature, and those are the two that we'll mainly discuss today and concentrate on. I do want you to be aware there are other cannabinoid receptors like we've mentioned before, but we'll be mainly concerning ourselves with CB1 and CB2. The CB1 and CB2 receptors are the most studied to date. They, in this image, are shown in different parts of the body. The endocannabinoids AEA, anandamide, and 2-AG, discussed on the previous slides, bind to these receptors throughout the body at various locations. CB1, it is the most abundant G protein coupled receptor in the body, and we see it in the highest concentration in the brain. We see a high expression of CB1 in the CNS as well as the peripheral nervous system. So when neuroanatomical studies were done, they saw this massive CB1 receptors being primarily located in presynaptic terminals of neurons that transmitted GABA, glutamate, and as well as dopamine, acetylcholine, norepinephrine, and serotonin. And so we think about those molecules that were involved that we just listed, and we can see how the CB1 receptor can affect such a wide variety of different biochemical pathways. There's also lower but functional levels of CB1 receptors located in the liver, muscle, fat, and blood vessel tissue, as well as the vasculature of the heart, pancreatic beta cells, reproductive cells, lung alveolar cells. CB1 receptors are in so many different places, but they are primarily located in our nervous system. Moving to CB2 receptors, these are also G-coupled protein receptors, and these are also expressed in the central nervous system, but they are expressed at much lower levels than CB1. They're mainly expressed at their highest levels in immune cells and lymphoid tissues located in the periphery. And interestingly enough, some conditions are characterized by a neuroinflammatory state. Some conditions that are characterized by neuroinflammatory states demonstrate an upregulation in these CB2 receptors, especially in glial cells. Next, we will talk about endocannabinoid signaling, and be ready. This is some of the more complicated slides that we'll go through. The endocannabinoid system is, like I said before, ubiquitous and somewhat complex. It innervates, again, almost all of our organs and tissue systems throughout the entire human body. And most probably enigmatically are the immune system and our nervous system. And so back to it, the ECS utilizes retrograde signaling. And so this means the message can travel both forward and backward from presynaptic to postsynaptic neurons. And so we have lots of different effects. We have effects where when there is a high level of intracellular calcium in the postsynaptic neuron, that can trigger a release of 2-AG and anandamide from the postsynaptic neuron. And 2-AG and AEA, or anandamide, they can pass through and over the synaptic cleft, where they will act on the presynaptic CB1 and CB2 receptors. So with the endocannabinoid signaling, with an increase in postsynaptic, we're just kind of going over this again in summary, an increase in postsynaptic calcium leads to release of 2-AG and AEA in the postsynaptic neuron. It travels across the synaptic cleft and back to the presynaptic CB1 and CB2 receptors. These, again, are G-coupled protein receptors, and these are primarily going to couple to the G-alpha protein, which you can see in the schematic. And when this happens, the alpha subunit will go on to inhibit adenylyl cyclase, which decreases production of cyclic AMP. So, and that ultimately will lead to a decrease in neurotransmitters released from the presynaptic cell. And in addition, you have a beta and gamma subunit that can act on the L, N, and P Q-type calcium channels. And these can stop calcium influx in the presynaptic cell. These have also the effect of opening potassium channels. So this is going to allow the potassium in the presynaptic cell to flow out into extracellular space, making the presynaptic neuron more negative, slowing neurotransmission as well, because it hyperpolarizes the cell. And while that's not it, these receptors can also have G-alpha subunits that are stimulatory, where the pathway can increase phospholipase C, leading to increased calcium inside of the cell. And we see this happening in astrocytes. We also have our non-classical signaling, sometimes called non-canonical signaling, demonstrating the true diversity of these receptors. They can result in receptor transactivation. They can heterodimerize with other types of G protein coupled receptors. They can affect the response of other G protein coupled receptors, causing desensitization. They can also play a role in autoregulation, starting or stopping themselves from working. These receptors have intracellular receptor signaling as well. As you can see, it's incredibly diverse. This is just a brief schematic, and if you look further into this subject, there's a lot more to learn. And moving forward to the next slide. In terms of activity at the CB1 receptor, we see 2-AG is a full agonist, meaning that even if there's only a small amount of 2-AG around, when it comes and occupies a receptor, it has a more of a maximal response. In terms of activity at the CB2 receptor, 2-AG is also a full agonist there. 2-AG is going to be synthesized in response to increased intracellular calcium coming into the cell. And that synthesis is going to take place using DAGL, or diacylglycerol lipase. After 2-AG goes and interacts with the cannabinoid receptor, exerting its own effect, it can then be degraded. And the enzyme that does that is MAGL, or monoacylglycerol lipase. And it breaks up 2-AG into arachidonic acid and then glycerol. And let's discuss anandamide. So in terms of activity at the CB1 receptor, anandamide is a partial agonist. A partial agonist is not going to have the effect to activate receptors to the same degree, meaning it may not be able to produce a maximal response like the one we see with 2-acylglycerol or 2-AG. But at CB2 receptors, it's also found to be a partial agonist. However, it's basically inactive, we think, at these receptors, even though it's considered a partial agonist. In terms of synthesis, anandamide is synthesized from an NAPE-specific phospholipase in the phospholipid membrane, and we have NAPE, specific phospholipase, which is going to cut out NAPE and then change that into anandamide biochem. So after the anandamide exerts its effect, it's degraded by FAAH, or the enzyme fatty acid amide hydrolase. It breaks that up into arachidonic acid and ethanolamine. To the next slide, where we discuss common cannabinoid benefits, we'll discuss the different cannabinoid agents and terpenoid agents and how they can affect our bodies. So what are phytocannabinoids? Phytocannabinoids are a group of cannabinoids, cannabinoid substances found in the cannabis plant. The main phytocannabinoids found in cannabis are THC and CBD, known as tetrahydrocannabinol and cannabidiol. And besides THC and CBD, more than 100 other cannabinoids have been identified. Now we will discuss phytocannabinoids that are specific to the cannabis plant. And the most specific, most commonly researched cannabinoids are THCA, THC, CBDA, CBD, CBN, and CBG. In the next slide, titled How Phytocannabinoids Bind with CB1 and CB2 Receptors, you could see in this schematic that THC is making its way to bind with CB1 and CB2 receptors on the presynaptic neuron. THC is a partial agonist and binds to CB1 and CB2 receptors, disrupting normal endocannabinoid retrograde signaling. Many of the identified cannabinoids from the cannabis plant can bind both CB1 and CB2 receptors. However, they have been found not to bind as tightly to the receptors as THC does. THC is the primary cannabinoid when we think about intoxicating cannabinoids. Many of the cannabinoids, including CBD, have found to be non-intoxicating. CBD does not bind directly to the receptor. Rather, it doesn't trigger the receptor directly. Rather, we found that it modifies the receptor's ability to bind other cannabinoids, both exogenous and endogenous. So CBD is an allosteric modulator antagonist. CBD is different. And in fact, all of the mechanism of actions that we have for CBD not only are not fully understood, but there are probably mechanisms of action we haven't even discovered for CBD yet, and in time probably will. There are multiple proposed mechanisms of action for CBD. CBD is an allosteric negative modulator, as we've already mentioned, or an antagonist at CB1 and CB2. CBD increases levels of anandamide, or AEA, due to AEA reuptake inhibition and CBD's ability to inhibit the FAAH molecule that degrades or breaks down the anandamide that we make internally. And we've also found that CBD can interact with the 5-HT1A receptor, or the serotonin receptor. We found that it can interact with the opioid receptor, as well as the TRPV1 cation channels, as well as dopaminergic receptors. So research continues to be done, and it's still very early to draw firm conclusions about all of the mechanisms of action of CBD, let alone the nuances of its mechanisms of action. But more research is being done, and we learn more every day. CBD gets a few slides because it has such a general and broad effect on so many different cannabinoid systems within the human body. This image outlines proposed activity patterns of CBD on targeted proteins related to various neuropsychiatric disorders. When we know that CBD affects the glutaminergic and dopaminergic and GABA inhibitory responses in our biology, we can understand, and also it affects the various others listed on this slide. We know that it can affect a big range of neuropsychiatric disorders. So in example 1 on this slide, we see CBD as an allosteric agonist at glycine receptors, specifically where maybe it could play a role in where we think autism spectrum disorder and epilepsy could come in. And again, as just another example, number 2 on this slide, CBD is an allosteric antagonist at the CB1 receptor. This shows us where it might play a role in psychosis or schizophrenia. It has so many additional effects. It deserves so much attention, so much of your attention. It cannot be stressed enough that if you leave my part of this presentation and do one thing, I would ask you to look up more about cannabidiol, or CBD. The proposed therapeutic uses of cannabinoids can be discussed further. In this table, we've outlined 6 of the most discussed cannabinoids in consumer products currently. THCA, which is the acid form of THC. We see that when used on its own, perhaps topically, perhaps however it's used, as opposed to THC, we see that it has its own effects, including its effects on inflammation, nausea and vomiting, neuroprotection, and potentially seizures. The list goes on. You can follow it down from THC, down THC to CBDA, all the way down to CBG. I don't need to probably read the potential therapeutic benefits on the right to you for each one. But of note, please make note mentally that CBD is involved in inflammatory pain and can have some effect on arthritis and migraine type pain and inflammation. And also note that CBN, or cannabinol, can affect things like sleep and can be used sometimes in an isolated form as a agent for anti-insomnia. Potential therapeutic benefits and uses of cannabinoids. We can see that all cannabinoids are derived from the acid form of CBG or CBGA, and that the various other cannabinoids identified to date are products of other cannabinoids. So, for example, THCA breaks down to THC with heat, and this process is called decarboxylation or decarbing. CBDA also breaks down into CBD with heat. Eventually, through time, oxidative stress, and light exposure, THC will break down eventually to CBN, the cannabinoid I mentioned on the previous slide, that can be used as an anti-insomnia agent. This image also discusses proposed therapeutic uses for cannabinoids that we haven't discussed yet, such as CBCA, CBC, CBDV, and THCV. As research continues, it's likely we'll learn an increase in therapeutic uses for these additional cannabinoids, as well as additional uses for the cannabinoids identified on this slide to date. Moving on to the entourage effect. In 1998, professors Raphael Mechoulam and Shimon Ben Shabbat hypothesized that the endocannabinoid system demonstrates an entourage effect in which a variety of seemingly inactive metabolites and closely related molecules markedly may increase the activity of primary endogenous cannabinoids that we make, such as anandamide or 2-arachidonyl glycerol, or 2-AG and AEA. They also postulated that this helped explain how botanical drugs and preparations were often more efficacious than their isolated single molecule components. And that led us and scientists to start considering and understanding how terpenes and flavonoids and recently other what they call volatile aromatics, and those may be sulfurous components, etc., understanding how those can affect the role of cannabinoids by just being present with them in a formulation, such that you would find like as a full spectrum or whole plant cannabis therapeutic agent. Terpenes and flavonoids, they give cannabis the smell, taste, and color. They contribute to the therapeutic and medicinal effects of cannabis, working separately, but both also together, contributing to a entourage effect together. The terpene diversity in cannabis, resin, and oils of the plant is responsible for its scent and flavor. Terpenes are found in almost every flower, herb, and fruit, and there are over 100 different terpenes in cannabis, with over 20,000 discovered to date in the plant world. And the type of terpene and quantity, or ratio, the unique bouquet, so to speak, can affect each person's endocannabinoid system differently. The main terpenes we'll concern ourselves with today are alpha-pinene, limonene, beta-caryophyllene, linalool, and myrcene. Alpha-pinene producing stimulatory effects mentally as well as bronchodilatory effects. Limonene being a somewhat stimulating anxiolytic agent, it's been found. Beta-caryophyllene has been found to have effects for anti-pain and anti-insomnia effects. Linalool has been found in lavender as well, for its sedative and antidepressant effects as well as its anti-anxiety effects. Myrcene having effects for anti-inflammation, anti-pain, and some sedative calming effects. These may be noted. And each one of these terpenes has its own aroma and consistency. And again, its ratio or bouquet when compared to other terpenes and their own respective ratios within different chemical varieties or what they call strains of cannabis are what give it its specific taste and smell, and almost with the entourage effect help guide the cannabinoids to do different benefits as far as whether it's observed from the patient to be a calming effect or a focused effect or a euphoric effect. The ratio of the cannabinoids to the terpenoids and the consistency or the representation of which primary terpenoid or cannabinoid is in the plant, whether it be limonene or linalool or myrcene, and whether the cannabinoid be THC or CBD dominant. These effects in synergy with terpenes and cannabinoids as a whole is what helps each chemical variety or strain of cannabis do its own specific things, even though it is a full spectrum or whole plant preparation. When talking about flavonoids, these are what contribute to the color and taste of the cannabis flower. There are 26 different flavonoids that we know specific to the cannabis plant, having different therapeutic uses. Mainly these are seen as antioxidant and anti-inflammation agents inside the plant. In humans, we could see that they could potentially have an effect and are being studied for their anti-inflammation effects, specifically in nerve and cardiovascular cells. Common flavonoids specific to cannabis would be cannaflavin A, B, and C. Those are being studied for neuroprotective, anti-inflammation, and anti-cancer benefits. Moving on to the last slide, we have a reminder, better together, the ensemble or entourage effect. It's the idea that this constituents being more effective together than individually to treat symptoms and conditions. So using whole plant cannabis generally requires a smaller dose of the primary active ingredient, like we see being THC or CBD. We see more of an effect with a smaller dose when we compare whole plant cannabis to straight single molecule THC or CBD. We can, with whole plant cannabis, usually produce the same or better effect than we could with an isolate of that cannabinoid for a specific treatment or condition. Varying ratios of THC and CBD are being studied currently for specific uses, and also different terpenoids are being studied to determine what their application would be in regards to various different disease states.
Understanding medical cannabis dosing. Medical marijuana dosing practices employ the principles of pharmacokinetics. These principles include knowing how the medicine will get into the body, how it is distributed or circulates through the body, how it's metabolized or broken down, and how it is eliminated or excreted. This can help in determining a patient's optimal dose to provide the most medicinal benefit with the least unwanted adverse effects. This also helps prevent tolerance buildup and proves to be very cost effective. Utilizing the principle of start low, go slow is helpful in achieving safe marijuana consumption to effectively treat medical conditions. Knowing the pharmacokinetics can help with determining the appropriate dosage form for a particular patient. Inhalation methods often have a rapid onset and a short duration of effect. Tinctures are slightly longer in onset, but a very quick duration of action. Topical agents may take longer to circulate within the body, however their duration is much longer. Similarly, ingestible agents, such as gummies, can take much longer to be absorbed, and their duration of action is much longer as well. Cannabis does not affect everyone the same way. Keep in mind that cannabis can have a bidirectional effect. This means that it can have one effect in one individual and an entirely different effect in a different individual. It also means the same individual can be affected by cannabis in different ways. Really important with mood disorders, stress responses, and cardiovascular effects. Opposite responses in the same individual may oftentimes be based on dosage, strain, and/or setting of cannabis use. Cannabis has a unique attribute in that it has a wide range of effective dosages for each patient. Most patients have a certain threshold dose for various cannabis products. below which they will actually experience a gradual increase in their health benefits over time, and above that, in which they'll start building tolerance, they'll experience diminishing of benefits, and more undesired side effects. This dosing phenomenon is known as a biphasic dose-response curve. There are many ways to boost the endocannabinoid system. We can do this by focusing on endocannabinoid system enhancing foods. Those can be hemp, flaxseed, walnuts, chocolate, herbs, and tea. Or we can focus on enhancing activities that stimulate or boost the endocannabinoid system. Some examples include meditation, yoga, or exercise. We'll soon discuss the many benefits of cannabis, but there are adverse effects as well. This slide demonstrates those. These are usually self-limiting and dose-related. Common adverse effects include dizziness, dry mouth, nausea, fatigue or somnolence, euphoria, depression, diarrhea, vomiting, anxiety, confusion, paranoia, tachycardia, and throat and lung irritation. These next slides are ingestible recommendations for THC. The most important portion of these slides are on the right-hand side. Begin slow, dose low. Start with 1 serving and wait. Do not mix cannabis with other agents, including alcohol, and be very careful to keep cannabis out of reach of children and pets. We encourage you to remember that these are just recommendations and each patient is different. Few medicinal patients will exceed 10 milligrams of THC per dose, but of course some will need it. Tolerance building is likely at higher doses, so be cautious in recommending higher doses early on and throughout medical treatment. Optimal cannabis dosing involves identifying patient goals, finding a dosage form and delivery method with the combination of cannabinoid and terpenes to achieve the desired effect. Considerations include discretion, treatment of a particular condition, sleep, and intoxication or drug interactions. Understanding pharmacokinetics can help determine what dosage form. Having patients record the side effects or the effectiveness of particular treatments, including cannabinoids used and the involvement of terpenes, will help determine the effectiveness of future treatment. Please encourage patients to find their optimal dose by understanding what it is they choose to treat, and always utilize the start low, go slow recommendations for cannabis dosing. Encourage patients to follow up with questions and document their experience. Pertinent to our discussion is understanding that there are potentially dangerous Delta THC products now available in the unregulated retail market. 2018 Farm Bill, Congress unintentionally created a policy loophole that allowed Missourians, including children, to purchase intoxicating hemp cannabinoid products like Delta-8 gummies, vapes, beverages, and other consumables in multiple markets without any oversight to testing, packaging regulations, or age restrictions. These products have now been determined to be unsafe for human consumption in many different situations, and no research or testing has been done to confirm the safety of those products when they've been consumed. Non-intoxicating CBD hemp can be synthetically converted into intoxicating Delta-8 THC, and this is how this loophole existed. That process involves the use of toxic solvents and acids, which may remain in the consumed product even after delivery to the consumer. Delta-8 THC has then been specifically marketed to children in products that mimic common snack foods or candy. In Missouri, there are currently no regulations imposing age restrictions to purchase Delta-8 THC. In addition, there are no safety, quality, or concentration regulations on these Delta-8 THC products. Delta-8 THC consumption in humans has also not been studied for safe use. According to JAMA article in 2024, over 11% of 12th grade students reported using Delta-8, as it was so widely available in the markets that unrestrict its use. THC side effects from Delta-8 include impairment of cognitive function, memory, judgment, hallucinations, and anxiety, nausea, vomiting, dizziness, tremor, loss of consciousness, death, drug dependency, and impaired driving and operation of machinery. Missouri Poison Control Center data indicates that 41% of Delta-8 THC exposures occur in children younger than age 12. As this slide demonstrates, Delta-8 THC prevalence has increased from 2019 to record levels in 2024. This data is for patients between 0 and 19 years of age. Missouri Executive Order 2410 will go into effect on September 1st, 2024. This condemns the sale of any food containing unregulated psychoactive cannabis products in the state of Missouri. It does not apply to products under the purview of the Division of Cannabis Regulation under Article 14 of the Missouri Constitution. The amplified availability of hemp-derived intoxicating cannabinoids poses significant health risks, particularly to children. These intoxicating compounds are untested in humans, unregulated, and are often sold to consumers without restriction. Missourians are advised to avoid these products and obtain products in a regulated market where safety is of paramount importance to the consumer. Packaging and labeling safety precautions should be distinguished between regulated products and unregulated products. The following 2 slides demonstrate the differences between packaging and labeling of regulated products versus products from an unregulated market. In the first slide, the large diamond on all of the packaging indicates that this is marijuana and THC is present. In Missouri, the label must include the Missouri producer number, testing lab license number, the batch ID number, a statewide tracking number, the production date, the best used by date, what is contained in the product, including ingredients, dosing information, and instructions for use. There are specific restrictions on packaging colors in order to not be appealing to children. All packaging and containers must be certified child resistant, and a web link or QR code link to the manufacturer is included as additional product information. In our next slide are examples of unregulated products available in the Missouri market. As you can see, this packaging is much more colorful. There are animations and candy descriptions which make them very appealing to children and minors. The labeling is unclear, and the information about packaging contents, intoxicating contents, and the dosaging amounts is not available or not clear to the consumer. There are small or no warnings indicating that intoxicating products are contained within these packages, including THC. These products are not made in Missouri, and nor are they tested. They have little to no manufacturing information, as well as any specific testing or safety information. These packages are easy to open, making them very accessible to children. Pharmacologic considerations. There are contraindications to cannabis use. Although there is no standard of practice guideline for cannabis, these contraindications are based on known side effects and their potential complications. Information on contraindications are included on this slide. Please consult a physician if you're pregnant, breastfeeding, have a strong personal history of psychosis, heart disease, angina, hypertension, irregular heartbeat, or a history of stroke. Pulmonary disease, allergic and hypersensitive reactions to the plant itself are also considerations. Cannabinoids share metabolic pathways with other drugs. Both use the cytochrome P450 system in the liver. Drug interactions at low and moderate doses are uncommon. Knowing the cytochrome P450 system of enzymes will help understand the metabolism of cannabinoids and allow medical professionals to evaluate the drug effects and possible drug interactions. Medication interactions can be found online on a interaction checker, such as Medscape. In general, most interactions occur in patients using high doses of cannabis. The potential interaction of some medications should be discussed with patients. These include warfarin or Coumadin, statin, cholesterol medications, especially at higher doses, erythromycin, azole antifungals, stimulants, and anticholinergic medications. CNS depressants have an additive effect to THC, and the efficacy of theophylline can be reduced. There are clinical considerations with cannabis. Cannabis use disorder is recognized in the 5th version of the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. This added cannabis withdrawal as a new condition. In the 2013 revision of DSM-5, abuse and dependence were combined into cannabis use disorder. This captures the behavioral disorder that can occur with chronic cannabis use. The diagnosis of cannabis use disorder is manifested by having at least 2 of the following occurring within 12 months. This includes using cannabis in larger amounts or longer than intended, unsuccessful attempts to quit or cut down, excessive time in acquisition, using or recovering from use, having a craving or urge to use cannabis, failing to fulfill major role obligations at work, school, or home, social or interpersonal problems due to use, reduced social, occupational, or recreational activities because of cannabis use, recurrent use in hazardous situations, use despite physical or psychological negative effects, using more cannabis to obtain the same effect, which is also known as tolerance, and using cannabis to relieve withdrawal symptoms. Severity is graded as mild, moderate, or severe depending on whether 2 or 3, 4 or 5, or 6 or more of the above criteria are present. Cannabinoid hyperemesis syndrome, or cyclical vomiting syndrome, is also a clinical syndrome known to cannabis users. This is typically seen in males younger than 40 who have a negative laboratory radiographic and endoscopic workup for cyclical vomiting. Severe symptoms of hyperemesis, abdominal pain that is typically epigastric or periumbilical, are prominent features. Symptoms are often relieved with hot showers or baths. Weight loss is not a prominent feature. Treatment involves cessation of cannabis use. The National Academies of Sciences, Engineering, and Medicine released the effects of cannabis and cannabinoids on health and found conclusive or substantial evidence that cannabis was effective in chronic pain treatment, as an antiemetic in the treatment of chemotherapy-induced nausea and vomiting, and for improving patient-reported multiple sclerosis spasticity symptoms. There was moderate evidence to suggest that cannabis was effective in improving short-term sleep outcomes in people who had obstructive sleep apnea, fibromyalgia, chronic pain, or multiple sclerosis. There was limited evidence that cannabis or cannabinoids were effective in treating weight loss associated with HIV and AIDS, improving clinician-measured multiple sclerosis spasticity symptoms, improving symptoms of Tourette's, improving anxiety, and improving post-traumatic stress disorder. Limited evidence showed a statistical association between cannabinoids and better outcomes after traumatic brain injury or intracranial hemorrhage. Given all we know about cannabis, the primary treatment for a medical condition falls within the realm of pain. In fact, 82% of all medical cannabis recommendations are for chronic pain, which affects 100 million people in the United States. Headache syndromes due to migraine, fibromyalgia, cancer-related pain, HIV or diabetic neuropathy, multiple sclerosis, arthritis, spinal cord injury, stroke-related pain or central pain disorders, and PTSD or psychological pain have all been studied and treated with cannabis products. Cannabis dosing for pain in certain conditions is suggested on this next slide. As you can see, the dosing of cannabis in pain does not typically exceed 10 to 15 milligrams of THC, particularly in early dosing. With the introduction of medicinal cannabis laws, we have found that healthcare spending has gone down in states where legalized medical cannabis is available. In fact, some studies show a 5.88% lower rate of opioid prescriptions in states with medical cannabis. This particular study only analyzed opioid prescriptions in Medicare patients, which typically view medical marijuana as a less appropriate medical option. Opioid addiction rates remain much higher than cannabis addiction rates, with the ill effects of opioids far surpassing those of cannabis. Research resources. The National Academies of Science, Engineering, and Medicine published the 2017 report on the health effects of cannabis and cannabinoids. U.S. government trials has access to all ongoing trials involving cannabis, and additional information on marijuana in Missouri can be found on the Department of Health and Senior Services website. We have included additional resources on this slide. Thank you for your interest. If you have any questions, please feel free to reach out to Missouri Cannabis Trade Association at mocantrade.org.